I'm Paresh Dawda, founder and director of Prestantia Health. I'm a GP based in Canberra. We're really passionate about primary healthcare and making a positive difference to the lives of people we look after and our communities. In Australia, we're about to undergo primary care reform. Because of our passion, we're really keen that we learn from other countries, experts who've gone through this journey to help stimulate a conversation and a dialogue that will build on the wonderful work we're doing.
I'm Leanne Wells and I'm an associate consultant with Prestantia Health. I've just facilitated the first vodcast in our series, Australian Primary Healthcare Innovation and Reform Vodcast series. We've just had a conversation, very inspiring and stimulating, with experts, clinical experts from England, the US and Australia. Going beyond diagnosing the problem that we've seen so many reports do, to having a deep and rich conversation about what implementation for impact means and involves in primary healthcare reform. Have a listen. Welcome everybody to the first podcast in the Australian Primary Healthcare Insights and Innovation series. It's an initiative of Prestantia Health and Audienced. So over the coming months, we'll be producing a series of these vodcasts accompanied by blogs, expansive sort of editorial style blogs, and making them available online. Our aim is to bring thought leadership and stimulating discussion to some of the more contemporary issues in primary health care. I'm Leanne Wells and I'm an associate consultant with Prestantia Health, and I'll be facilitating the discussion today. So our topic for this first podcast is achieving high-performing health systems. How can we close the chasm between good policy intent into real service transformation? So our focus is squarely on improvement, innovation, and change implementation. And joining me today are some of the world's best minds in primary care improvement innovation from across the world. We have Dr. Kirsten Meisinger, Director of Leadership and System Transformation at the Harvard Medical School Centre for Primary Care. We have Dr. Johnny Marshall, OBE, from the UK National Association for Primary Care, and Johnny's also the past or former president of the NAPC. And Dr. Paresh Dawda, a GP leader and advisor, internationally and nationally recognised as a primary healthcare improvement expert, and the founder of Prestantia Health. And I know you all have several other roles and sets of expertise. They will be outlined as we post this podcast online. So we're not spending all our time with bios, but rest assured you'll learn more about our experts and their background and why they're so well placed to speak on this topic today from the material that accompanies this podcast online. Okay, so to set the scene, we've seen yet another round of reports on our health systems around the world. There's been the Darzi report, the IPPR Commission on Health and Prosperity reports in the UK. There's been the recent 2024 Mirror Commonwealth Fund report, particularly examining the performance of the US system, but also comparing the performance of systems across Commonwealth nations. And in Australia, we've had a litany, it feels, of task force and expert advisory group reports. Across all of those reports, they paint a sobering picture, I think, about what is ailing our health systems. But on the plus side, they all seem to be singing from the same song sheet. While we all have different systems, Kirsten, Johnny, Paresh are working and operating as clinicians and GP and primary care leaders in different systems, they're all saying essentially the same things, these reports, that community and primary health care and preventative care is where we need transformation and where we need investment. So I want to ask each of you to briefly tell me what most stands out to you from some of those most recent reports? So I might start with Kirsten first.
Thank you, Leanne. I appreciate the introduction and the setting of the stage. What really leaped out to me about these reports and the similarities between them are really three things. One is that the data, as something that we really need to get in order at the national, regional, and local level. Data really is our guide for equity and for quality of care. And when we don't have that, we lose out on the opportunity to really lean into what our patients and our communities really need for their health. Which leads to the second major spotlight in these reports, the commonality of looking at things at the population level. And honestly, this feels to me like it's been a change that we've been aware of since the start of computation and the ability to look at big data sets. We're now leaning into this kind of work, I think, at the health system level, but we haven't always connected primary health care and particularly primary care, the practice of access in all of our health systems to that data and to that mindset of a responsibility for everybody in our neighborhood, particularly not in the United States. There are places that have used a geographic model. The public sector called the SUS in Brazil, Cuba are notable, really wonderful systems, but they have to date lacked the power of data to really look across their population, although they have the infrastructure on the ground to be able to have people access primary health care as the way to coordinate care across the entire system. We've done that to a very limited extent in my country, much, much better in other countries, simply for the access. I do think one other useful point to maybe think about is that I think we're really in the middle of a third revolution in technology. If you think about the first revolution in technology was really the infectious disease burden that we used to have, right? And if you want to think about it, really all we had to do as healthcare was wash our hands, right? Once we figured that out, things got much better. The standard of living, of course, outside of the healthcare sector had a huge impact on that. The second revolution, I would say, is really an interventional revolution, and that really happened, between the 50s and the 80s. Cardiovascular, other major interventions that really allowed us to prolong lives, save lives of people who would otherwise have passed from an emerging chronic disease burden. Smoking cessation awareness, I think, is also important, but that really then is more of a healthcare-based intervention. The third one I would argue is actually using some of the data in population and the ability with AI to look at incredibly large data sets. And that's really the cancer revolution. We now have another way for us to live even longer in our incredibly now rich and hopefully across the entire world extensive lives. And I think that these are interesting phenomena. How does that relate to primary healthcare? Well, it actually underlines the need for us to increase our care coordination. And care coordination is not done retroactively. It's not best done in specialty. It's actually the job of primary care. So our long lives are underlining the increasing urgent need for us to really figure out how to coordinate our care across our population using all of the technology and the tools that we have available and using our incredibly well-trained, incredibly mission-driven primary care workforce.
Thanks, Kirsten. To you, Johnny, what most stands out to you from some of the recent reports, particularly in the UK context, Darcy and the IPPR report?
Thanks for that, Leanne. I think at face first pass, what strikes me most is the commonality between them, the sense of care closer to home, prevention being increasingly important, and a move from analog to digital. But I think it's important you get behind that and recognize that care closer to home, for example, is not just simply translocating acute disease-focused services into the community. It's actually using some of that data and insight to understand what the needs are of the people that live in those homes. So you can then start to reimagine what the care and support model might look like. So although there's a lot of commonality, I think it's important we are really clear about what we mean in order to achieve success. But the second thing, I guess, is that very little of this is new. From an NAPC perspective, we have been promoting this agenda for about 2 decades, and yet we're still struggling to see it become business as usual within the UK or really anywhere else in the world. So I think the real challenge is, how do you make the sense of every pound you invest in primary care delivering £14 worth of value to the economy? How do you make it a reality? How do you actually make this business as usual?
And Paresh, to you and your perspectives on these reports.
Great. Thanks, Leanne. And look, I really agree with everything Kirsten and Johnny has said. As I read these reports, to my mind, there's nothing new that really comes out. They emphasize, I think, what we've known for a long time. They emphasize the equity agenda, particularly, I think, comes through strongly. They talk about the need for personalized care, individualized care, person-centered care. Now, these are common words that we've used for a long time, and they just emphasize, I think, more and more in these reports. They talk about integration, bringing health systems together, but actually being cross-sectorial about integration as well, thinking about social systems and bringing that together. I think, in our context in Australia, we have health, we have aged care, we have disability care, we have social care, all sort of organized, working in their own unique ways, not really talking to one another. And I think the commonality, which you said earlier, Leanne, is the solution to a lot of the wicked problems, whether it's in the US, in the UK, or in Australia, seems to be strengthening primary care. The primary care system can actually deliver across that whole agenda: equity, person-centered care, integration, and really bring that together. And I think the final point, which I think Kirsten identified, is a technology. We are really in a technology revolution. Now, the law of accelerating returns tells us technology is going up at an exponential rate, and we really need to think about how we harness that in an optimal way in healthcare. We've not been very good in healthcare at adopting and utilizing technology in a purposeful way. So I think that's our big challenge.
Thank you. Okay, so I want to really get into exactly the nub of the question now, which is how we implement. The how question is the thing. The World Health Organization has published a playbook on how to implement change to deliver impact for health. And that strikes me as a really construct. And I know each of you, as I said, work in different systems, but there seem to be common solutions, as you've all alluded to, about how we can apply that playbook. As you said, Johnny, how we can move the practical system, service, level steps, personalised care steps, technologically enabled steps that need to be taken in an implementation sense to make good quality, safe, high equity primary health care business as usual and just solidly part of the DNA of our health systems. So to each of you, if we are to transform and future-proof primary health care, can you briefly tell me what your treatment plan would be to get primary health care back on track? What do you see as the top 3? I'm going to put that discipline on you. What are the top 3 game changers that you see systems need to implement to, as you said, Paresh, really bolster primary health care? I'll start again with you, Kirsten.
Thank you, Leanne. So my top three are starting again with data. I do love data. I don't love numbers. I love data. So one of the things we can do with our data is to actually, again, use it to really define where the intervention is most needed and those most in need. The second point is to rethink access as something beyond our healthcare infrastructure. Where are people interacting with healthcare? Wellness, supermarkets, wearables. We have a responsibility to embrace the use of healthcare sectors that are beyond what we think of traditional healthcare, because our patients have moved ahead of us and we owe it to them to be able to really bring that back into our relationship with them. The last thing I would argue is that technology really has a responsibility within primary care to embrace relationship. Technology can be fragmenting. And what we need to do is we need to use the technology, embrace the technology as a way to increase the relationship that we have with the people that we serve, and to be able to bring healthcare again into a more intentional cadence and not worry about our cultural past of one doctor, one patient.
Fabulous. Johnny, your thoughts, your game changers, your top three game changers.
Thanks, Leanne. Thanks for the discipline of really focusing, I guess, on what the most important things are. I think that, so for me, the three are, we have to build real teams in the communities that are matched to the health and wellbeing needs of the very communities that we serve. So we really need to understand what they are. We need to work with the communities to reimagine what that care and support offer might be, build the skills into the functions of those teams, and then have the necessary sort of, I guess, training and ongoing support and evaluation to check that they're doing a good job. So we have to build real teams around the needs of our population. And the second thing, I guess, is this sort of sense of the approach to population health and looking at what matters to people has to be adopted across the whole of the health and care system. It's too difficult it's too easy perhaps for some sectors to disregard this as being their business. But this needs to be the whole healthcare system's business, to make sure that we are aligning all of our resources, our understanding of the data, our skills in bringing about change, how we change financial flows, so that we're really all backing this completely. It cannot just be left to primary care. And the third thing is we have to recognize that maybe the 21st century is the century of systems, but every system requires a network to deliver the change that it needs to deliver. And we have to back our networks. And within the UK, that would be, well, certainly within England, that would be our primary care networks. We need to understand, I think it was Ed Wagner who first talked about the fact that health and care systems are built from one-to-one interventions between empowered people, carers, families, and prepared, proactive professional teams. You have to build this from the bottom up. So we have to invest in leadership skills within our frontline staff, working with the populations that they know, and then activating the whole workforce so that we all understand that we have a role in delivering this with our communities together.
Fabulous. Thanks, Johnny. And your top three, Paresh.
Great, thanks. I'm going to start by a really provocative statement: stop building shiny new hospitals, because I think we get stuck in mental valleys and we keep doing more of the same, and we've got to create a constraint to force us to think differently, to think creatively. I think that constraint is stop building shiny new hospitals, because that will allow us to divert that investment into other models of care, into primary care-based models of care. That investment, I think, will yield dividends in the long run. So that's my number one. My number two is workforce. And I think particularly in Australia, workforce is a big issue. It's particularly a big issue the further we go away from our metro places. So as we go into rural and regional places, it becomes an issue. We've got a shrinking primary care general practice workforce. And I think the comments made earlier about teams, enabling teams, working as teams, is something we really need to think about, build on, and have the enablers, regulatory enablers, the financial enablers, put in place so we can work authentically in teams within primary care. I think it's a big issue in Australia, particularly. And my third is going to come back to technology, is harnessing technology and really looking at what's emerging, particularly around the artificial intelligence and generative AI field. When we're thinking about technology in healthcare, we think about tomorrow's health systems with a mindset of today's technology, but tomorrow's technology is going to be exponentially better than today's technology. And so we've got to think with a mindset of a future health system and, the technology that will be present when we get there in 2, 3, 4 years' time. And I think that technology is around all sorts of things. I think the insights we get from the data Kirsten was talking about, really important. I think that technology will provide more data, but I think will provide us with more data insights, meaningful, purposeful insights. I think diagnostic and the use of diagnostics, that technology will improve. I think the efficiency of processes, the technology will help support us with. I think moving away from that sort of care delivery model, which is often one-to-one, often in clinic, to a multimodal way of delivering care that's appropriate and fit for that person. So they're my three. Stop building shiny new hospitals. Let's really think about the workforce and bringing the workforce together into authentic teams. And let's think about harnessing technology in a purposeful and meaningful way.
I think that Paresh's comment about authentic teams is really important. And we know that within Michael West's work in the NHS, that there are some really important characteristics about a team having a common purpose, having to work together to deliver, and evaluating what they do to make sure they are more effective than working on their own. So the sense of real teams is really important as we build this team-based approach in primary care.
So I would say representing the United States with the UK and Australia is a challenging proposition. I'm up for it and I appreciate the grace. One of the things that has happened in the United States is because of the incredible inadequacy of our primary care workforce, we have got teams. And listening to our two panelists speak about the need to build teams does at least make me feel better about the work that I have done over my lifetime in primary care and in the United States, that we have teams and they work beautifully. So please do embrace team.
Great call to action, and I think we're on that path, but there's a way to go, isn't there? You've all talked about you alluded to this, Paresh, planning for the future, but with current paradigms and mindsets is not the way to go. If you're Google, if you're Apple, the corporate world has, they don't have 5-year plans. They don't have 10-year plans. We have a 10-year primary healthcare plan in Australia here. They have 30-year plans. It's that the rate of transformation, as you suggest, Paresh, is going to probably overwhelm us in healthcare over the next 50 years. So it's that really future-mindedness and future-proofing our system that we really need to be thinking about. And it brings me to, or reminds me actually of a quote, something David Bowie famously said, that tomorrow belongs to those who can hear it coming. And I thought that was quite neat. It's referring to his what people thought of or perceived as him having a degree of clairvoyance, I suppose. But commentators on that quote from David Bowie have said that it's a quote that embodies his propensity to recognise change, his propensity to capitalise on that, and being ready for change when it comes, or actually being the agents of change ourselves and the various roles we play within the system. Because when you can see tomorrow coming, you can own it, you can do something about it. So it's about setting a North Star, I suppose. It's about having that big, hairy, audacious goal for health systems and the primary care set of arrangements we need for the future. And you've all touched on what some of those future characteristics and roadmaps for primary healthcare transformation and innovation are. So this is my last question to each of you. What does your tomorrow for primary healthcare look like? How do you reimagine primary healthcare? I'll start with Johnny.
Thanks, Leanne. It also reminds me of the quote, "The future is here, it's just not evenly distributed." And I think if you look around the best of what's happening, UK, Australia, and the US, which has some really good stuff, as well as having some challenges, and you put that all in one place, then I think you'd have a healthcare system that recognizes that primary care isn't about the primary care disciplines. It's not about general practice, pharmacy, etc. But it's a functional description that thinks about first point of contact, thinks about comprehensive support. It thinks about sort of personalization. And I think if you then start to roll that forward, you move away from thinking about disease and illness and biomedical models of support, and you start thinking about creating health. And you start thinking about how important that is. And you recognize that only 10% of our sense of well-being comes from healthcare, and the other 90% comes from almost every other factor in our life that's important to us. So I think if we're serious about the future, we've got to start looking at it in a very different way, but recognize this is often happening around us. So maybe if I look back with a letter to myself in 20 years' time, what I'll be experiencing is a much greater sense of thinking about health, playing a much larger role in how I stay well and keep fit, supported by community-led initiatives around how I sleep, move, eat, connect. That keeps me connected with the environment and the people around me. And there will be a team in the background, a real team. And I think that's important, that when we're building teams, we build them that they're really effective. And there's some really interesting work from Michael West in the UK that distinguishes a pseudo team from a real team, which we can unpack if that's helpful later. But real teams who've just got a sense of a proactive view of what's going on around me, what's going on with me, that are offering me the opportunity to continue to work to improve my health. They're helping me to remove the barriers that might sit between me and being healthier. And at the end of that, it's a sense of me feeling very much that I'm in charge of what's important to me, that I am part of the central part of that team that is ensuring I'm living the best, healthiest life possible. I think that exists now in places, maybe not within formal primary healthcare, but it exists around us. And I think the challenge is, how do we start to formalize that, set it on fire, and make it part of what the primary healthcare teams represent?
Kirsten, thanks for those comments, Johnny. Fantastic insights. Kirsten.
Thank you, Leanne. I'm going to extend, I think, what Johnny talked about. And I think we do need to get serious about people's ability to self-design their care and also their access to care. So I would actually like to see everybody in the United States be within less than a 10-minute walk or a 30-minute drive of a GP, but a GP team, not a GP as an individual. And why is that? I know that team care is the most effective way for people to be able to interact with healthcare. I also know that they're interacting across the spectrum of wellness and other ways to embrace health, because fundamentally the healthcare sector is actually quite reactionary and specialist dominated. And we think of things in problem lists, and patients, right, who are actually people, think of themselves as whole beings. And if we can't move our paradigm into that mindset, then we are going to become increasingly marginalized and irrelevant. And one of the things that we can do is we can use technology and we can embrace the paradigm shift of letting our people, our patients, our communities design their own healthcare teams. Why not allow them to connect people that are meaningful to their definition and self-definition of health, things such as nutritionists, midwives, traditional healers from multiple cultures. We all live in multicultural environments. Why not allow them to network all of those people into their healthcare team and allow us to have the humility and the grace to let them take charge of their health? Since, as we know, the disease burden and the is now chronic disease, and we're going to all be, hopefully, living a very long time. But in aggregate, we are living a very long time already. So I would love our ability to embrace humility within healthcare, let our patients actually take charge and guide us for what they need and design their own care. And we become a complementary and very important part of that as trusted primary care teams in their lives.
Thanks, Kirsten. And to you, Paresh, what's your tomorrow look like?
Yeah. Thanks, Leanne. And look, I think my colleagues have done an amazing job. And how can I add to what they've done? I start with perhaps what shouldn't change, because I think that keeps us focused on what can be different. And what I think shouldn't change is what's dear to us. It's the caring, the compassion, the relational, the human aspects of providing care. And for me, I think that's the constant, that's not negotiable. Everything else is up for disruption though. And so for me, it is very much about co-production, working with people together to meet them where they are in order to deliver their care, deliver their health. It's about being bound by no boundaries. So healthcare doesn't necessarily happen in general practices or medical clinics or hospitals. It actually happens in the community, in neighborhoods, in places where people go to. And sometimes that might be in a medical center, but more often than not, it won't be. As Johnny said, 90% of health is determined by factors outside of direct healthcare delivery. So I think it's about not being bound by boundaries. And I'd like to sort of bring in the sustainability issue. And I'm not just talking about financial and workforce sustainability, but environmental sustainability, because I think we need to bring that into the equation. It's very much aligned. So if we have practices that are environmentally sustainable, it will actually improve health. What we eat, the diet we have, the appropriate use of pharmaceuticals, all of those will actually reduce and improve our carbon footprint and create a sustainable environment. But in doing so, it'll also create health. And so I'd like to pull in the environmental sustainability part into the equation when we're reimagining healthcare in the future.
Thank you so much. Well, that brings us to the end of the discussion points I wanted to cover off with the three of you. And what amazing insights you've had to offer. In the health policy discourse over the last couple of decades, you can't help but get despondent sometimes, can you, about so many reports, so many task forces, so many committees, so many politicians, consumer groups, clinical groups, diagnosing the problem. So I think what I've taken from the discussion from three of you is such amazing, I suppose, insights and a hopefulness that we can change. It's not all bad. We can disrupt in a positive way. There are some things that are good already that we don't want to change, that we should be building on, that could be accelerated. But there are some very real disruptors and forces of change that can be harnessed right now, not on the horizon, but right now. But there will be things on the horizon as well. So I'll turn to Paresh in a moment to make some wrap-up remarks. But I guess just from my point of view, a couple of brief reflections. And there's several reflections I could offer, and I don't want to repeat or go over everything you all had to say. It was fantastic. But I suppose probably the three or so takeouts for me from the conversation was that if we are to implement and transform healthcare, it does need to go beyond primary healthcare. We need to be thinking about the factors across our lifestyles and other parts of the economic and social ecosystems that we live in and work in. And I guess that's why countries such as Australia and others are starting to move towards well-being economies and well-being budgets and frameworks like that that count in a very serious way against or account or report against metrics other than the traditional economic GDP metrics about how we are doing as societies. I think it's about, what I also heard was that it's often about different, not more. It's about doing things differently, perhaps investing in different ways, disinvesting in some parts of the system, as you said, Paresh. Stop building those shiny new hospitals and, look at something else. The point about building real teams, the point about health creation, but I guess importantly to me, one of the takeout messages, and given my background as former CEO of the Consumers Health Forum of Australia, the point about personalised care, but much more than personalised care, empowered personalised care. Your point, Kirsten, about care being self-determined and healthcare design resting in the hands of patients and communities, and the system and teams and providers and services being mobilised around that in a way that patients and communities are empowered to determine much, much more than they currently are. I could offer a lot more reflections, and we'll do that in the accompanying blog to this vodcast, but I'll hand now to Paresh. This is a Prestantia initiative, Paresh, this vodcast series, so over to you for some closing remarks from you on today's discussion.
Great, thanks, Leanne, and thanks so much, Kirsten and Johnny. I always get so energized and enthused by such conversations. So you've kind of given me my boost for the next month at least, if not longer than that. So thank you. I really loved what you said, Johnny. The future's here already. It's just not distributed. And I think, Kirsten, your comments about data and that learning system, using data to learn and identify what's working and spread, I think can help us. So let's identify where the future is, like where are the places that are doing this already? What can we learn from them? What does the data tell us? And let's sort of start to build from that. I think, Johnny, you talked about leadership, and that's absolutely critical. So how do we invest in primary care leadership to take this sort of agenda forward? I think is really critical. Kirsten, you reminded me about the importance of relational working and keeping those relationships alive. That's the thing, I share with you in terms of something we really don't want to lose. Whatever we do, let's make sure it builds on that relationship. I think the idea of working with communities, together with communities, co-design, co-produce, is absolutely critical in all of this. So they're my kind of main takeouts. And I think from a Prestantia Health perspective, we all share the same problems. So, there's a real opportunity for us to globally do things together which is absolutely fantastic. The cross-fertilization between our respective countries, the sharing, the knowledge, the learning, I think is almost critical to do this. I'm actually going to finish by actually going back to something Kirsten's told me in the past, which is, when we're thinking about these things, and as we're looking forward, little incremental improvements is what we do. When we look back, it's transformation. And I think those were very wise words, Kirsten, and they've stuck with me. So I think that's the way we approach this. We just keep going, we learn, we improve. We'll look back in a few years and we'll see transformation. Thank you.
Thanks very much, Paresh. So Kirsten Meisinger, Johnny Marshall, Paresh Dawda, thanks so much for your insights today, and thanks for helping us launch the Australian Primary Healthcare Innovation and Improvement Vodcast series on such a positive, progressive and inspirational tone. Thank you very much.
Thank you.